Next, I would like to invite Dr. Meena Chakrabarti to talk on macular plug analysis of SD-OCT changes leading on to hole closure.
Good afternoon, everyone. In the next few minutes, I would like to share with you our experience in performing a modified technique of macular hole surgery, which did not involve intraoperative fluid air exchange or gas or air tamponade or post-operative positioning. This procedure was done in large stage 3 and stage 4 macular hole with a mean base diameter of greater than 1000 micrometer. The modification in the technique that we employed include performing a very broad internal limiting membrane peel and inverted internal limiting flap repositioning into the well of the hole, and the use of autologous gluconated blood clumps to form a macular plug to close the hole. The blood clump was prepared at the time of surgery by withdrawing about 2 cc of blood from the antecubital vein after prepping and draping that area, and then mixing it with about 2 cc of 5% dextrose. This was a retrospective consecutive chart review of 40 eyes with stage 3 and stage 4 macular holes with a mean base diameter of more than 1000 micrometer who underwent macular hole surgery by the macular plug technique. These were our exclusion criteria. We collected the following data from the case records: the mean base diameter of the macular hole, the postoperative OCT findings, the postoperative best corrected visual acuity, the intraocular pressure, and whether cataract surgery was necessary in the postoperative period. For the purpose of the study, we defined the criteria for success as anatomic success was defined as hole closure and restoration of the outer retinal integrity, and functional success was if we achieved a 2-step improvement in the logMAR visual acuity from the baseline vision. This is an animation of the technique that we perform. The first layer of the plug is autologous blood. A broad internal limiting membrane flap is created and gently nudged into the well of the hole and nudged under the edges of the hole. The third layer is again autologous gluconated blood. This is a video clipping where the autologous gluconated blood alone was used in the entire macular hole surgery. The blood was used for delineating the posterior hyaloid, a PVD induction, and the same autologous blood was layered over the macula and used for internal limiting membrane peeling. We did a broad area of ILM peeling, and in most of the cases the rhexis was performed as a 2-stage macular rhexis. The ILM is gently stuffed into the hole, and because of the presence of the autologous gluconated blood at the base of the hole, it sticks down without getting dislodged. This is the postoperative result on day 1, day 7, and day 14. We use the Cirrus 500 SD-OCT protocols, the macular volume scan protocol, and the macular cube of 518 into 518 and 200 into 200. We also did the HD 5-line raster enhanced depth imaging OCT. And this was repeated on day 1, 7, 14, and day 30. We looked for hole closure, the inner and outer layer apposition, and we looked at the integrity of the outer retina in terms of the retinal pigment epithelial integrity, the coastline, the ellipsoid zone, and the external limiting membrane. This is one patient who had a laser-induced macular hole while working in a dermatology clinic and using Q-switch laser. The mean base diameter of the hole was 1472. This is the preoperative OCT. This is day 1, which you can see a loose plug bridging the hole. Day 7, there's a well-formed plug with partial restoration of the outer retinal layers. This is on day 14, where there is restoration of the outer retinal integrity was established with improvement in the best corrected visual acuity from 5/60 to 6/9. This is another patient who had a redundant floating internal limiting membrane, which persisted up to 12 months into the postoperative period. This is a third case where there was healing and apposition of usually the healing occurred from the inner retina to the outer retina. In this patient, the healing occurred from the outer retina to the inner retina in the reverse direction. This patient had excessive proliferation of the macular plug, which did not significantly affect his visual recovery. And in this patient, the persistent cystoid edema persisted up to the 20th postoperative day. One patient had a dislodged internal limiting membrane flap, which we converted into an autologous ILM graft, and the same flap was used to form the macular plug with good visual results. Analyzing our results, we looked at the apposition of the inner retinal layer, superior and inferior to the fovea, was achieved on day 1 in all the eyes. Persistence of the foveal defect occurred up to day 30. Restoration of the outer retinal integrity, the RPE integrity, coastline, external EZ and the external limiting membrane was seen up to on the day 30th in all the eyes. And in one eye, persistent defect in the outer retinal layer and persistent defect in the ellipsoid zone was seen, which persisted up to 12 months into the postoperative period. There was a patient who had incomplete restoration of the ellipsoid zone. Visual acuity improved from 6/60 to 6/18. We could achieve whole closure in 34.61% of our patients by day 1, 80% by day 7, and 100% on the 30th postoperative day. Comparing our visual result with the preoperative vision by using the Wilcoxon sign rank test, it was statistically significant. While harvesting the internal limiting membrane, we took care to ensure that there was a broader area of membrane attached to the margin of the hole. Multiple layers of membrane were stuffed into the hole. We achieved a slightly hyperreflective elevated plug on the first postoperative day. There was no signs of retinal toxicity. A word of caution in that strict aseptic precaution should be followed by withdrawing blood and mixing it with 5% dextrose. Eliminating postoperative face down posturing and complications of gas tamponade without compromising the macular hole closure rate has significant advantages for the patients, and flat open type 2 closure could be avoided in all our patients. A larger series with longer follow-up is necessary to validate our results. Thank you very much for your patient hearing.
Madam, it's a wonderful study, madam. I would like to know about, was there any control group for this?
No, this was a retrospective case series, case by case. We did that. It was not masked and there was no control group.
Because you have done both ILM peeling as well as autologous blood, and it is a good thing that there is no gas or no prone position required. However, if I remember the history of macular hole surgery in the olden days there was autologous blood was being used, at which time the surgical hole closure rates were not very good, where afterwards, after the ILM peeling has started, the surgical rates have improved. So I would say that it would be better to have a control group where you have done only the ILM peeling and no autologous blood. So at least it would be better to analyze in such a way that whether it is the ILM peeling or the autologous blood which is causing the hole closure in your
We are continuing our study, ma'am. We'll look into that also.